Thank you. I understand I am what separates you all from happy hour today. But I'm a faculty member. I could talk forever. So you got to hope that I'm paying attention to the time there. And it's really hard to follow Marlon. But what I want to talk to you about a little bit today is kind of flipping the ready for everything by building community capacity, by really encouraging civic engagement or community participation. I have a Margaret Mead quote here. Those of you who are social media savvy probably see this come up on your Facebook feed all the time, right? It's an inspirational quote that says that the world is changed by a small group of committed citizens. I find it inspiring. I think it's kind of feels like an American ideal. I have a second quote from maybe a less famous person on a similar speaker. This is House Speaker Paul Ryan, saying that basically every successful individual is surrounded by a community of people that brought them there. I think this is almost a uniquely American idea, that democratic participation in all aspects of society is how we reach long-term sustainable democratic change. We look at it in our government, we look at it in our civil society, we look at it in our churches, we look at it in a variety of places in our lives. Where we don't always look at it is in healthcare. And I want to talk to you a little bit today from the perspective of a nurse and a public health nurse about why I see this as important in healthcare. If you don't already know it, and many of you are in healthcare, so you already do, we spend more money than anybody else on the planet on our healthcare system, and we don't really achieve much in the way of outcomes. Our outcomes are not horrible, but they're mediocre. The Institute of Medicine about 3 years ago did a study where they compared US health outcomes with 17 other countries that are at similar levels of economic development with us. So countries that you would expect us to compete with in the healthcare arena. And indeed, we did well in some things, but we didn't do well in a whole variety of things. And a couple of them are really notable, even if you're not a healthcare person. One is life expectancy. So infant born today, how long on average can they expect to live? And the second is infant mortality. Infant born today, how many of them will make it through the first year of life? Those are two really key outcome indicators that tell you something about how healthy a community is. We were dead last in both of those when you compare us to the 17 peer countries. So two kind of really critical indicators that we don't do so well despite the fact that we spend all kinds of money on this. We also know that we have problems in healthcare, even with our outcomes, with disparities between groups. Racial, ethnic disparities, we talk about health inequity. Disparities by where you live, disparities by gender, gender orientation. We know that, so even our outcomes as they are not equitable across the country. We also know we have a variety of other kinds of healthcare problems. We have chronic diseases that, again, more telling in minority communities and communities of low income. Not only do those communities have higher death rates and lower life expectancy, but the quality of life for people in those communities as they deal with chronic illness like diabetes, heart disease, obesity, is really much diminished. We know we have new and infectious diseases coming out, Ebola and Zika in the last couple of years, that we're going to have to deal with as a society. We know that in many communities, and Chicago has become the poster child, we have a big problem with interpersonal and community violence, both in the homes and out in the street. We know that we have a variety of health policy challenges, and I could list them forever, but the ones that are most recent and really caught our attention because I thought we had fixed these a while back is, if you've noticed that northeastern Indiana is having a big problem with lead in their water, and the people in Flint, Michigan still don't have safe and clean drinking water, and that's coming up on 2 years. So we have a large variety of health issues. What does community engagement mean for those issues? What does it bring to the table? So I'll tell you why I came to this interest. I told you I was a public health nurse, researcher, educator. Many years ago, before I got into public health, I started in acute care in nursing, as many new nurses do. And this was a long time ago, and people stayed in the hospital for a long time. And I would get to know my patients, and I would spend time with them, and I would tell them how they were going to take their medicine and how they were going to test their blood sugar and activity levels and what their diet should be like, and then I would send them home. And a week, 2 weeks, 3 weeks, a month, many of them came back in the door with the same problem that we had thought we had fixed and sent them home with. And as a fairly new nurse who had really put a lot of time and effort into that, I was astounded. What had gone wrong? How come they didn't listen to my great advice and somehow fix themselves up when they got home? What was happening in those communities? So I left acute care and went and worked in home health care for about a decade, where I went into where people lived and worked and played. And it was a great humility lesson for me, because what I found out was what I had been telling those patients for all that time was pretty much irrelevant in their lives. And they had been very nice to me, and they had been patting me on the hand and smiling at me and going home and doing what they could do given their resources, their capacity, their community, their home environment. So when I went into home care, I found that the little old man that I said, don't eat canned food because you want to really watch your sodium intake, because sodium will cause you to retain fluids and that will put excess burden on your heart. He was unable to get up and down his third floor walk up, and he had a neighbor who shopped for him once a month. So if you get food in your house once a month, it's going to be canned food, and that's what you're going to eat. The little old lady who took care of her elderly husband, and he needed a lot of care, and so I would remind her, take care of yourself too. When I got into the home and met them, she had no backup. She was 24/7. She couldn't even get a good night's sleep, much less a chance to take a walk around the block or get her hair done or go to church or anything else that might have been re-energizing for her. The woman that I set up and said, here's what you need to do during the day, here's when you need to take your medications, here's the activity level you should have, found out later that her family was glad to have her living with them, but they had to work 10-hour days. And so what they did, because she couldn't get around on her own, was they put her in a chair in front of the television set at 8 in the morning with her food, her pills, her water, and then they came and helped her again at 6 at night, because that's all they could do. So besides the humility, which was obviously well needed for me, I thought of two things that I took out of that experience. One was that I had spent time with my patients, but I hadn't engaged with them at all. I had just talked at them. I hadn't really listened to them and what was relevant to them and what was real and what their lived experience was like, so that we could work out together what they might do to improve their health. And the second thing was, a lot of what affected people's health happened outside of the clinical setting. Here I thought I was in the center of the universe. I was in an acute care setting, and doctors and nurses are relatively irrelevant to most of what makes people healthy or not healthy. Most of what happens to people in regards to their health happens where they live, work, play, and pray. So I decided after that I was going to go into public health to find out a little bit more about all of these things that happen outside of the healthcare system. This is the health impact pyramid. I learned about it many years ago as the social determinants of health. Now in healthcare, everyone talks about the social determinants of health, but actually public health people have been having these conversations for 40 years. Nobody would listen to us. This health impact pyramid is from Dr. Tom Frieden, who was the head of CDC until the new administration, so about 4 months ago. And it's hard to see from here, but the bottom of the health impact pyramid, so the pyramid, the things at the bottom have greater impact on the health of populations and communities. The things at the top require greater resources. So the bottom is things like socioeconomic factors, because really, health is greatly impacted by the resources you have available, whether you have a job and income. It's greatly impacted by your educational level. There's a really strong correlation between education level and health. It's greatly impacted by whether you have safe housing and whether you have affordable healthy food. The second one here, it says changing the context to make individuals' default decisions healthy. Turn that into making the healthy choice the easy choice. What can we do that makes it easier for people to make healthy choices? So one thing would be we put recess back in the Chicago Public Schools recently, so kids are able to get activity on a regular basis, don't have to go and start special programs. It's part of their daily life. Or we've made cigarettes more expensive and made it harder. We can't smoke in public buildings, so that we make that unhealthy choice a little bit harder for people. So these really high impact, relatively low cost things are where we don't spend as much time, where we put a lot of our energy as clinical interventions and counseling and education. Well, those patients need to know more about what they do. Now those are good things and they're impactful, but they're very resource intensive, particularly compared to the outcomes you get from them. So the more I learned about this, I took this into my practice as a public health nurse in the community. But there's a variety of challenges trying to make this happen, and I'm just going to talk about a few of them. The first challenge I found was conflicting priorities. So I go in as the public health nurse. I was working in Robert Taylor Homes, which was a public housing complex on the near South Side in Chicago until a few years back. And I would go and I would talk to women about the infant mortality rate in Robert Taylor Homes, and it was horrible. And the women were concerned, and they thought that wasn't a good thing, but it really didn't feel relevant to their lives. What felt relevant is this was the late 80s, the crack cocaine epidemic was a big deal. There was a lot of gang warfare about who was going to sell crack cocaine. What felt relevant to them was that they sometimes had to walk their children to school and walk past a chalk outline because someone had been shot outside their building. Or they couldn't send their kid out to the vacant lot to play or down to the corner for a gallon of milk because of the level of violence in the community. So how do you juxtapose those two things? The data is correct, there is a problem, but the lived experience is also correct. There is a problem that people need to deal with every single day. The second set of challenges I found was commitment and sustainability. In my community work, and I'm sure this has happened to any of you who've done this as well, I can't tell you how many times people said to me, who is getting their PhD from this? What are you doing here? And who is going to get their degree from this work? Because people in the communities I worked in were a little bit jaded. They had seen people, particularly people from universities, come in, do a project, collect data, and leave. And then the next group came in, and the next, how many times are you gonna, drink the Kool-Aid with the folks that came in, no matter how nice they seemed to be? And so I had to think about being honest with people about what my work was and how long I was gonna be there, and I had to think about what I was gonna leave behind. So is it doing something and walking away, or is it doing something with people so that they've developed new skills and this is where they live, can continue the work after we leave? And that gets into whole conversations about ownership and what participation is. It is relatively easy to get a bunch of people together and say, we want to hear from you about your issues. It's a little bit more challenging to say to those people, let's get together about how you can impact those issues. Not suggesting that we don't need government, hospitals, healthcare organizations, churches, et cetera, but you are the missing part of the equation here. And how can we get you meaningfully involved in setting the direction of what's going to happen to make this community a healthier, better place? The third thing was to look at assets versus needs. John McKnight from Northwestern helped with this when he said, we go into communities and we do community health needs assessments. And what you do is you leave the community with a whole laundry list of needs. When you leave people with a whole laundry list of needs, what they feel like is that they are passive consumers who need help to fix all of their needs. John McKnight said, let's take a look at the assets in communities as well and help them think about how they can bring their assets to address their needs. And all communities have assets. It may be the park. It may be the closeness to CTA, to public transportation. It may be the public library, which is a clean, safe space that's open to everybody. It may be individual capacities. Maybe somebody bakes a great pie. Maybe somebody can fix cars. How do we help communities see all of those things they have and bring it together to help them address their needs in ways that work and are sustainable and are capacity building? And the last challenge I want to talk about is the idea of resilience versus capacity. So the Department of Defense and the RAND Corporation have been doing a lot of research on community resilience. How come you have two communities, they look a little bit alike, a disaster happens, one comes back, and the other really just has a hard time recuperating? I want to switch that around and say, how do we build community capacity so that, yes, if a disaster occurs, God forbid, they're able to recoup, but that they have capacity on a daily basis to help improve the health and well-being in that neighborhood, to help get stronger and better every day. The California Endowment has this quote on their website where they say, if you can plug the community into the right kind of political power grid, it'll do more to create health and wellness than any other single intervention. It is the untapped thing. We do a little bit of talking about communities, but mostly it's to get them to participate in the things that those of us in healthcare have already decided to do. Mostly it's to say, oh, we asked for your opinion and we got your opinion and now we're still going to go ahead. It's not serious civic engagement of the type that I think Margaret Mead and hopefully Paul Ryan were talking about. So the last thing I want to talk about a little, so what I've done more recently in this work is I had sabbatical last year, which is a lovely thing, and I looked at the concept of community engagement and spent some time in the literature, as we like to do, and then I went and interviewed people around the country who have done successful community health and development projects, and I said, how did you involve people at the grassroots level? What worked, what didn't? What challenges did you find? What wisdom do you have to share? And I'm in the midst of analyzing that data right now, so I don't have anything definitive, but I have a few themes that I wanted to share with you as kind of a positive thing. One thing they said is strong civic participation. You really need to get people involved from the get-go. A woman in Maine says she does something called community circles, where she brings groups of people together. Some are community residents, some might be professionals or church leadership, around an issue. And she said sometimes it doesn't work. Sometimes they'll meet once or twice and say, you know, we got nothing for each other, we're going to disband. But some of them have been very effective. So her mental health community circle has been meeting every 6 weeks now for 4 years. And they have actually developed some things that they've implemented in this small rural community to help people with mental illness cope better and to help the community figure out how to support them better and how to live congenially together. The second thing that people, my interviewees have told me, whoops, wrong thing, is that engagement starts at home. And you got to start by knowing your neighbors. And I think that's true for all the communities we belong in, not just the ones that I work in, but the ones that I live in as well. The West Side Health Authority here in the Austin neighborhood in Chicago has a project they've been working on called Every Block's a Village. And what they've tried to do is take blocks and say, let's connect people on a block, because you can get your head around your block. It's not that huge. Let's find out what the assets and the needs are and see if we can connect people on this block to solve those immediate problems, but also to create ongoing social connectedness. So if this is the retired couple at one side of the block who has a little bit of extra time, maybe they can do childcare for the young family here who the parents have to work and they could use some less expensive childcare. And in return, the young couple will come and cut grass and shovel snow and maybe take them to the doctor occasionally. So it's a lovely model to start at the very small to create connections across community in very concrete ways. Civil discourse is another thing my interviewees talked about. It's really important that we learn how to talk to each other in a civil way. I think we've particularly lost that in the last year or so in this country. We're going to disagree. We probably couldn't all agree on what to order for dinner if we got together and someone offered to buy us all dinner in this room. So how do we spend the time and energy it takes and use conflict resolution skills and use communication skills so that we can get to know one another? We can recognize our differences, but try to find some larger commonality that we could work on together. And through the course of doing that, get to know each other and trust each other and maybe be a little bit better at addressing some of our differences. The one thing all of my interviewees agreed on is that it takes time. There's no shortcut for this. It just takes time and attention and commitment. One of the stories that people told me was community health centers have to have 51% of their board as community members. And she said they would always have dinner before the board would meet. And a lot of times the professionals wouldn't come to dinner. They didn't have time, they were busy, they would just come for the meeting. What they found out is when everyone showed up for dinner, the later business meeting was much more productive because people had a chance to develop relationships and start to trust, and then they were able to work more effectively together. The last thing my interviewees shared with me is community action strategies. We have to figure out ways, and some of them had some methods, like my community circles lady, and hopefully as I get into the data, we'll find more. We have to find ways to develop mutual goals, again, even beyond our disagreements, and then how to develop structures for action. It's not enough to set goals if we don't do anything about them, and our structures for action have to be inclusive so that people feel like their participation is meaningful to the overall effort and to their expenditure of their time. So how do we develop those inclusive structures knowing that people are going to ebb and flow in their participation? You may be at a time when you have an ill family member and you can't spend as much time in your community. Other people may be at a time when they've retired and they have more time. So knowing that we're going to have that ebb and flow, how do we keep those structures going? The last thing all of my folks talked about was we need to think about the long-term horizon. So we need some short-term outcomes, like setting up getting a clinic to come into our community, or cleaning up a vacant lot, or getting a playground. But we need to have the long horizon. We need to think we're in this to improve the health of this community and the well-being for the duration. And that means a commitment and a long-term set of outcomes. And that means we need to talk to our government and philanthropy people about a long timeline for outcomes as well. So the last quote I want to leave you with is a hero of mine, Marian Wright Edelman, who says, "The challenge of social justice is to evoke a sense of community that we need to make our nation a better place, just as we make it a safer place, and I would say, and a healthier place." So have a good weekend and go talk to a neighbor.